This is lecture number 8 in Nursing 210 Concepts. What we're going to be looking at today is healthcare delivery systems. And of course, this lecture was composed by Dr. David Sharp, so we give him full credit. Looking at our second slide, we see that there is an illustration. See concentric circles, the patient being at the center and towards the top. And then we see the healthcare professionals are next, the infrastructure, which that is the hospitals and clinics. Any kind of healthcare institution that you can think of can fall into that. And there are the regulators. These are the government agencies. These are the insurers, the researchers. Any kind of governmental system that is actively involved in regulating healthcare in the United States. Looking at the levels of health services that are available, we look at the first one as primary care. And I'm sure you've heard of primary care providers, primary care health care. That is looking at health promotion and preventative care. For example, immunization programs are a form of primary care. The primary focus is on health education, and we want to get early detection and treatment for any kind of illnesses or diseases. We are maintaining and improving optimal health. That is our overriding goal. That's exactly why we are providing service. And in the primary care level, we are trying to catch everything in its earliest possible stage or phase. Then when you look at secondary care, the focus shifts towards emergent and acute care. This can be not only an emergency department, it can be urgent care clinics, or it can be an acute episode that causes you to be admitted to the hospital. But most of the time, these are provided in hospitals and other acute settings. This phenomenon of urgent care settings that are 7 days a week without appointment, that is very, very popular throughout the country now, and they can deal with acute situations. They cannot admit, but they can suggest that you go and be admitted, or they can provide antibiotics or corticosteroid or any other kind of prescription treatment that you might need to deal with an acute situation that can be taken care of at home. Now, the emphasis is on making a diagnosis and treating that, and usually they deal with complex disorders. In tertiary care, that is our most complex care. That deals with your rehab services, your LTACs, your long-term acute cares, long-term care, ambulatory hospitals such as where nursing homes, care of the dying such as hospice, etc. These are very complicated cases, very complex. You're dealing with not just dealing with an acute situation, but usually a mixture of acute, chronic, and possibly end-of-life issues. Now, we as registered nurses, we work in all these levels of providing these services. We work in the primary, secondary, and tertiary. We work in both hospitals and community settings. That's your choice. The next illustration, you see that the patient on this human pyramid is at the top with an IV bag. Then we have the healthcare providers, and we have the regulators on the bottom foundational rung. Now, the thing about healthcare delivery systems is that they are very complex and they are multifaceted. Especially in the United States, we have a very complex healthcare delivery system. Nurses usually provide the majority of healthcare services. They are the hands-on people. You may have a physician step in and deal with a client for 15 minutes, and then the rest of the day it's the nurse that deals with the patient. We need to understand the role that we play in that system. What is it exactly that is expected of us? What do we accomplish? What are the tasks we perform? We have documentation to do. We have to make sure that all the T's are crossed and the I's are dotted. Now, for the next 4 semesters, you are going to be learning what that role is. Now, the problem is that it's an ever-changing thing. The healthcare system, it just changes from one year to the next, sometimes less than a year. New laws are passed. New protocols are put into place. New standards are put into place, and you have to keep up with those things as a professional nurse. But we as nurses, we need to be at the forefront of change, and we need to be very proactive in enacting change for the better. So you've got to understand these systems and how they relate to one another. Nursing itself is as complex as the healthcare systems that we participate in, that we work for, that we're involved with. Nursing is a very complex profession. It occurs in a whole wide variety of locations throughout the country. You could even travel overseas and still be doing nursing that is United States based, but it's in another location, but your parent company may be here in the United States. You can work anywhere from hospice to hospital to home health. You can work in cancer treatment centers. You can work in doctors' clinics. You can work in all kinds of clinics. So the role of a nurse varies just as much as the healthcare system itself varies. But caring and compassion does not vary in the role of a nurse. We always offer care and compassion no matter where we work, no matter what the location is, whether it be in a rural or whether it be in a large city, whether it be in a different country or whether it be here at home, whether it be in a clinic or a hospital. We always have that fundamental ethical value of caring and giving compassion to our clients. But we also need to understand and develop our roles as nurses. Now, these roles are changing. We have advanced practice nurses and we have practical nurses. So you've got a wide range of scopes of practices and a wide range of roles. So we need to have a good grasp of what those are. We need to be willing to change along with those roles too. We will have a significant impact on the future development of the healthcare system. Especially as a professional nurse, you will be the one that will need to be proactive in making it work. You will be doing the hands-on thing. You will be ministering to the clients. You'll be talking to them, caring for them, changing their bandages. You will be giving them their medications. Now, instead of a group exercise here, what we're going to do is I'm going to ask you to just take a paper and pencil and jot down some of these things. Design a system, a healthcare system that will address the healthcare needs for a particular population group. What will you need for that? Okay, write that down. Then describe the facilities that you think you would provide and outline how a person would enter into the system. In other words, how is it accessed? And look at how do you pay for such a system. Just as kind of a fun exercise, go ahead and pause the audio, take a piece of paper, and write down your thoughts on this. You're welcome to share them on a discussion board, of course, but this is not a graded assignment. So just take your time, think about it, look at your Catalano text if you need to, and just come up with some ideas, and then you can share them on a discussion board if you like. Just pause the audio for a few minutes. Now we're back and we're looking at types of global healthcare systems. We've typed these as 1, 2, 3, 4, and the third world alternatives. Type 1 has to deal with the private health insurance system. It has physicians, staff, and clients that have autonomy. So the physicians, the staff, and the clients have their own decision-making process that they go through. Clients who can afford it choose their service. So they're not dictated to as to where they have to go or etc. They get to choose who their providers are and which hospital they want to go to. Some public funding, though, is required even in this private health insurance system for those who cannot pay. Sometimes these are sliding scale fees. Sometimes these are co-pays. Now looking at the type 2 of the health insurance provider, we're looking at national health insurance. Now they take egalitarian values and combine them with a practitioner and client autonomy. They use the tax dollars to pay for health insurance, and that comes from a nonprofit agency, which is usually the government, the central form of government. But each health service within this type 2 operates autonomously on its own, so it's not a dictatorial type of thing from the government. All services are then paid from a central pool of health insurance funds that is created by taxation of the people. Collective sharing of burdens and benefits while allowing a degree of autonomy in the delivery of the healthcare system. That's your type 2. Now we look at type 3. Type 3 is a national health service that is funded and operated by the government. Totally funded and operated by the government. It's based on the egalitarian values of the society and the government themselves, and its efficient and effective operation depends on public management. Then we move to type 4, and we call this the socialized health system or social medicine. It focuses on keeping the general public healthy so they can contribute to society and economy. And you see, healthcare is viewed as an essential service, or it is the right of each individual human to receive an equal amount of health care that the fellow citizens do. So everyone is equal in this system and they all receive health care in an equal way, and they consider it their right, not a privilege, but a right. The goal of this type 4 social medicine is to keep productivity high via a healthy population. So you can imagine that they're really stressing primary prevention in this type of system. Physicians are agents of the state who keep others working efficiently. So many times the physicians in these systems are paid by the government, and they're like supervisors who supervise the social health care system. You see the next graphic has to do with the different countries and their health insurance coverage. See, the colors represent total public, private, and no health care. Now, what about the third world alternatives? Well, usually they cannot afford health care, and it's not available to them. So it's only available in developed countries. So that's a very, very stark contrast when we look at third world countries. And this creates a lot of compassion for us nurses. Many times we go do volunteer work in third world countries. Yet most third world countries have developed some kind of a primary care system. It may not be as complex and rich or well funded as these other systems, such as the type 1 and 2 and 3. And it's not dependent on institution as it is in developed countries. We have many, many healthcare institutions and systems within our system and within social medicine. Third world is not dependent upon those kinds of systems. They focus on preventative care and continuing care. Primary care is the first point of contact with the health system, and sometimes Western high-tech and institutionalization have undermined primary and preventive systems in these third world alternatives. Now let's do another little exercise. I'll go over these with you, then you can pause the audio and do this, and either share it with us on the discussion board. It's not going to be graded or anything. Think of someone you know personally who has a health care need, and don't write their name down. Just think of them, and you could put their initials down. Do you know what their medical history is, what their current problems are, and what they might need in the future? So what health care setting do you think would be most appropriate for them? And can you anticipate any problems with this person entering the healthcare system? So how could you as a nurse facilitate this process? So pause the audio, write down your thoughts on this, share them on the discussion board if you wish. Now we're back looking at healthcare in the USA. We have a different method of funding administering a healthcare system. Is it a system? It's kind of a hybrid. We have both Medicare, Medicaid, private funding. We have all of these different kinds of systems that feed into one healthcare system in the United States. Now, the World Health Organization reports that the USA spends more on healthcare than any other country. The overall quality of care ranks as number 37. Now, that seems to be diametrically opposed. You think that the more that we spend, the better care we get, but that doesn't seem to be the case. What could be the problem? So the USA is the worst and last among the 7 leading industrialized nations. That just doesn't sound right, does it? So we see there's a disparity linked to the cost of services. It's not the quality of service available dependent upon the cost of service. So you may pay a lot of money for an MRI, and it may not be the best quality. It's just what they charge for that MRI. You may not receive the best care in a certain hospital, but they seem to be overpriced. That's a disparity. Looking at the next slide, we see the healthcare spending as a percentage of the gross domestic product. You can take a look at those for a few minutes. Might have to zoom in on it. Where are we at? A high percentage of the GDP goes to healthcare. And here's another table from the WHO, the World Health Organization. They're ranking the world's health system. Where are we at? Number 37. Not good. That can cause quite a debate, quite a discussion. It probably should. We need to address that issue. Now let's look at the National Coalition on Healthcare findings. The primary reason for being uninsured is a lack of health coverage insurance. So it's that people just don't have the health coverage. But as health care costs rise, the number of insured people decreases. Half of the American public is very worried, very concerned about how they will meet increased health insurance premiums. So the premiums keep going up. The cost of it goes up. It doesn't go down, it keeps going up. 25% found paying for health insurance was a problem. That means that if you can't afford it, you don't get it. But medical debt is the leading cause of bankruptcy in the United States. 50% of bankruptcies are because of medical debt, and the average medical debt is $12,000 per person. So the bigger the family, the bigger the medical debt. It just keeps climbing and climbing. How about elderly couples? When they retire, they're going to need $200,000 to $300,000 just to pay for the medical coverage for the rest of their life. This seems like a phenomenal task, a challenge that they have to face. Now, we passed what's called the Patient Protection and Affordable Health Care Act in 2010. It was one of the largest healthcare system overhauls in the last 50 years. It was passed to provide health care to people who were unable to pay for or obtain their health coverage, and also loosen the stranglehold of insurance companies on healthcare systems. It addresses inequities in coverage and helps senior citizens. 32 million citizens added to healthcare rolls out of a total of 47 million who needed it. Some provisions of this are the supplement to limit for drug coverage provided by Medicare for senior citizens, the care of all children up to age 26, eliminating pre-existing conditions also for adults. The insurance companies cannot drop a person if they get sick. Insurance companies must reveal how much they spend on administration and overheads, elimination of health insurance fraud, less expensive care plans for retirees. But there are some concerns about this. The anticipated gradual increase in premiums, but most people will qualify for subsidies. They're hoping that that will offset that. Federal plans will not cover abortion. Most Americans will have to buy health insurance by 2014 or face a penalty. Invasion of privacy and limit on personal freedom arguments. This is what comes up. This is the argument we're having at this very current time. Is it less burdensome to pay the penalty for not doing this than to go ahead and do this? But their general overall theory was if everyone pays, it's cheaper for all. Otherwise, those who pay have higher premiums to cover those who don't. And then there's a fear that increased number of clients will flood the system. What if we flood the system and physicians retire out, and there's nursing shortages, and there's healthcare institutions that will no longer provide services? They'll just close down, or they'll reduce the number of people that they can care for. So let's go to our text and look on page 360, and you'll see there's a case study. Nursing home falls pay big. Take a few minutes, pause the audio, and read that case study. And what I'd like for you to do is just form your own opinions. Think about it. Look at what it's saying. And then just go ahead and share your thoughts on the discussion board if you wish. This is not a graded assignment, so you don't have to do that. Or just mull it over and you can bring your thoughts when you come next semester. That concludes our lecture for today.